Can you hear me now? Okay. We can go until 2:45. We've been giving some bonus time.
Okay, so Pam Goodwin, Toronto. These were great talks, and so were the ones in the last session this morning. I think there's been some discussion about the extent to which oncologists are open to these types of interventions. And I think Bernadette this morning talked a little bit about what might be perceived as oncologist reluctance to address some of these issues. I think that may actually reflect the fact that they have to do many things and they focus on what they're good at, and they're not good at this. I don't think they're really resisting having discussions of lifestyle change, but that they need someone to refer to or someone to do the discussion for them. And it's the same with trials. I think in the last 5 to 10 years, thanks in part to the ASCO initiative that Jennifer has led, but also to a lot of the emerging data, I think that in academic circles, there's been a much greater openness to addressing or considering lifestyle and physical activity, weight loss and physical activity interventions. But I think much of the community has been raised and trained to practice evidence-based medicine. And until there is good evidence of effects on cancer outcomes, for the most part, you're going to see physicians open to interventions that will improve symptoms and quality of life. We had a little bit of a discussion this morning about a couple of very small studies that might raise concerns about weight loss or physical activity interventions, but I don't think that is weighing in on how physicians are addressing this. I really think that they want to have someone who will do this because it's not their area of expertise and they've got a lot of other things they have to do. But when they do it, they want it to be properly put in front of the patients. In other words, this may help your symptoms, your general health, your physical well-being, your quality of life. But I think there's still a lot of concern and reluctance regarding the cancer outcomes.
Can I just answer that question?
Hi, yeah.
Pamela, I agree with you fully. The oncologists have expertise in a particular area, but I think the message that I was trying to get across is that the patients need to hear from the physician that this is important, but then the physicians or the provider, whichever provider it is, needs to have resources to guide the patient to do the heavy lifting, because they don't have the skills or the time or whatever to work on a one-to-one basis with the patient. And a model like that, and has worked in smoking cessation as well, I think takes the burden off the provider, but at least the message is heard by the patients.
Yeah, so even materials or handouts to give to the patient and say, this is something you really need to consider. We have this group doing it.
I at least in Chicago, and I was partnered with Northwestern, University of Chicago, and University of Illinois Chicago, and the oncologists there were delighted that they had a program that was in the neighborhoods on the south and west sides of Chicago to refer their patients to, because patients were asking for information and resources, and they had nowhere to send them. So I think if we can offer them something to refer to, they will be very eager for that.
Hi, Karen Bassanenquist from MD Anderson Cancer Center. Thanks very much. This was a terrific panel. I really enjoyed it. And I have a question, and I guess it mainly would be directed at Melinda, but any of you might have some thoughts about this. And it's about kind of cultural specific interventions as opposed to having an intervention that tries to address the needs of people from multiple from a diverse ethnic background. So, I live in Houston, very diverse city. And, I hear about programs that people do or studies people do where you're targeting African Americans or Latinos, and I've done some of those. But in truth, when we think about trying to affect clinical practice in a city like ours, we can't say, well, here's what you give to the African Americans and here's what you give to the Hispanic ladies and so forth. So, kind of what are the trade-offs there, and how can you maybe incorporate some of the sensitivity that you want in from a culturally specific intervention into a more general intervention?
Question, and I wish I could have put more in my slides, but I think that we know that cognitive behavioral weight loss therapies work, right? There's the evidence base in the general population about what works. And I think when I coined that phrase lifestyle navigator and talked so much about context, is that the base of the intervention can be similar across populations, and then tailoring, it should be tailored even to individual patients, right? You could have the same basic weight loss intervention for a 40-year-old with 3 kids at home and an elder person, right? But you're gonna contextualize that different for those populations. So I shined light on racial ethnic minorities, but I think we need to be thinking, again, that socio-ecological model, that yes, this works, but let's tailor it to each individual with what works for them. So I can tell you, having done obesity treatment, I did that in my clinical practice. And I think we can do that effectively in large programs. It's just research forces us to pinpoint particular populations, and that is not disseminable.
Can I just follow up on that? I think that we have to address several issues even to get to that. We have a pipeline issue. We don't even have diversity in providers. It's so minuscule. Even the staffing, I don't mean just people who are going to run around and hand out papers. I mean, even the well-educated staff have to be diverse. Doesn't mean, I have a very diverse group. People are here from my group. Doesn't mean we all are black by any means, but we have a diversity in our staff. So the people see and they hear from different people, and we can adjust and modify accordingly. Whether it's black, white, Indian, Asian, that's fine. But I think we have to start thinking about pipelines, and I don't think we give enough thought to that. We can sit around and look at this room. We don't have a pipeline of diversity sitting here, and it will continue forever unless we can figure out how to solve that problem. But until we do, it doesn't mean we need to stop our research, but I think we have to think about how do we diversify in an academic level. I hear people talk about, I won't call out my institution or any institutions I've been at, but when you say that you have a very diverse group and all the diversity is secretaries, it's not a diverse group, and those things constantly happen. So I think when we talk about in the sciences, even if we're talking about pre-docs or postdocs, and we see a diversity in that group, I think we can grow. So that's just my bias.
I'd like to follow. My name's Kirsten Arup. I'm with the University of North Carolina at Chapel Hill, and I'd like to follow up on Dr. Goodwin's comment about the role of clinicians. I'm a PhD, I am not an MD, and I don't play one on TV. So, but I work in the Division of Hematology Oncology, and I've been doing since 2014 studies that are all totally clinic-based in cancer survivors. And I think that we need to have a little bit more research about what the provider is willing to do. We did a quick little chart review, and we looked at medical oncologists in breast, prostate, colorectal cancer, medical oncologists, surgical oncologists, radiation oncologists, and they all varied in the extent to which they were willing to have the conversation about physical activity. And I think that it varied greatly. We looked at individual clinicians, and it varied from some that were having it 90% of the time to those that were having it 0% of the time. And as one of my colleagues said, she said, yesterday I spent a half an hour talking about energy imbalance. And she's a breast cancer oncologist seeing very serious patients just like everybody else. My other colleague says to me, Kirsten, I love your studies, but until you show me beyond the epidemiological evidence that physical activity is important to survivorship, I'm going to just talk about the things I know. So I think we shouldn't take it for granted that clinicians don't want to have the conversation. I think they're going to vary, just like patients will vary in terms of their receptiveness to the physical activity conversation or the weight conversation. But I think we need to have a little bit more listening to a wide variety of oncology providers about what they're willing and able to say. And if it's just as little as, it would be important if you could kind of think about some physical activity all the way through, here's about energy imbalance. I think we can make some progress because there are a lot of patients and survivors that want to hear it from the white coat. They really want to hear it there. That's their savior. They saved my life. And so you can start there, but you don't have to ask everybody to, put out the kitchen sink. But just, it probably does mean a lot to a lot of cancer patients and survivors to hear from the clinician. That's just a statement. More research needed.
Hi, Eric Hansen, also from UNC Chapel Hill. Having only done a single study in prostate cancer patients that were a minority group, this panel here confirmed a lot of the suspicions I had and was very informative. So thank you for that. My
Suspicions.
well, just some of the the disparities in the differences we see within the populations between, let's say, I said white populations and all others in this case. And so, what my question revolves around is, we saw a number of data that were showing higher rates of obesity and poor prognosis and such in the minority populations. Now, while this isn't my area, but I was under the impression that even in non-cancer populations, some of these same issues are there. There's greater prevalence in that. How much of that, in your professional opinion, is, due to the population that has an elevated rate, and how much of it might be due to, within a specific cancer population, if that makes sense?
The difference in disparity between cancer-specific mortality and comorbidity mortality? Is
In a
that your
sense, so yeah.
question?
So, for example, if there was a 5% difference between, said whites and Hispanics in the general population, and how you said then is there then a 10% difference between whites and Hispanics in the cancer population, or is that difference?
Is it overlap? So
Yeah,
there's
just curious
data
as to how
that
much
looks
it is.
at cancer-specific mortality, so separate from everything else. So you see higher rates of cancer-specific mortality. That's what I showed for the SEER data. Okay, but then you also would see an even further bump. And they do think that contributes to causes of overall mortality among minority survivors that are associated with comorbidities.
Great. Thank you.
Turkan Gardner from Pragmatica. I was very intrigued by Dr. Stolley's presentation relative to different gender groups and race groups. I used to work with data on cancer mortality, all of them that were available, mapping them, and trying to correlate them across types of cancers and types of causes of death from maps that were produced by the National Cancer Institute and National Center for Health Statistics. And I tried to get one composite for each state and each county, because the shapefiles were by states and counties. Until I discovered that in trying to run cross correlations about types of cancer, the means and standard deviations were so varied across gender and race groups that my initial query of why they had separate maps for males versus females versus blacks versus whites just got answered, because the assumption that we make in running correlations is that they are similar distributions in terms of variability and in terms of the averages. And they were completely different. So then I started admiring the reasons why we have to acknowledge differences in gender and race groups and look at them on a geographical scale, including all the other types of variability causes that you have so lucidly presented here. Thank you.
Tasha Moses, Strategic Management Services. I really enjoyed the panel. I think all of your presentations were great. One thing that I wanted to ask for each of the presenters is that in the research that you have these groups of individuals that you pull together and bring them in for this research. And I'm just thinking about the populations in particular that I've worked with who were trying to recruit for trials or recruit for research, in addition to the negative stigmas associated with research, particularly in the African American communities. One thing that I also hear is, you get me involved in this trial or this research, I have a positive outcome, or you implement this positive intervention, then what? So my question to each of you guys is, then what? I think the, final presenter did mention that, you're looking at, you have some opportunities, but have you taken those opportunities a step further? Have you looked at some social service organizations or churches or other types of organizations in the community that you could potentially partner with and bring them on board to maybe continue on the work that's being done so that these individuals don't feel like you just left me out in the cold after you brought me in, and they don't get that sense of feeling used? Because there's a lot of African Americans, I can tell you right now, they're hesitant to enrolling in trials, and being a part of research is not just that negative stigma associated with research, but also that feeling of being used. So what are you doing to address that?
Yeah, so thank you for that question. That was exactly the feeling I had when I was about 2/3 through with the rural breast cancer survivor that we did, is what are we doing next? And a lot of the women in that study were really engaged and became really advocates for us. And that's why we started looking at where can we try to implement this, and thought about YMCA, thought about cooperative extension, and really kind of landed in primary care as the more local healthcare system. In our primary care trial, the average distance traveled is 10 miles versus 60 to the local oncology practices. So many of the women in that study now serve on our patient advisory board. So we're trying to keep that patient activation and advocacy going in our state and region, and hope to come back to cancer survivor population in our work.
And to kind of speak to your comment, this is why it's very important also to have cost effectiveness as an outcome here, because truly, if we're going to be sustained, the churches are one method, but people don't go to their church necessarily to get their health care. Let's face it, you go there to nourish your spirit, not necessarily your bodies per se. We really do need cost studies on these things so that the healthcare does pick them up, that third-party payers can pick it up, and I think we're going to hear more about that this afternoon.
So a couple of points I want to address, and also thank you for that question. One is we have a responsibility to disseminate the results of the studies, and not just through medical journals. So one of the things that we did, and this was part of our community advisory panel, is we've held semi-annual town halls where all the women and their family members and any community member wants to attend at libraries across the south and west sides of Chicago to talk about here's what we found, here's what we're hoping to do. We don't have funding. The next step for us is we want to do a dissemination and implementation study in public rec systems in Chicago and Milwaukee to find out, is this a class you could just put on your rolls that women could sign up for $10, $20 and get the program? There's, it would be great. I know the DPP covers, or insurance covers the DPP at Livestrong, but funding is always an issue. And I know the public rec systems are very, very eager to bring this program on, but they also need funds to train their staff. And if I don't get the funding, I'll find some way to do it. I'll go to foundations. But I felt the same way. I feel terrible, and we try to maintain something through newsletters and these town halls. But I think even saying that up front, which we did, that we're trying, that we don't want to do what's been done in the past, is really important.
Let me just add one last thing, and that is when I came to Georgetown, one of the things I required was, part of my startup was to be a part of the community. So we had to have a community-based office. So my office, all of my faculty and staff are located in the community, so we're part of the fabric. So we don't give the impression of doing helicopter science, which is the biggest negative thing that you can ever do to minority communities. So I think by our setup and really engage with the community through our community advisory boards, through our patient navigation program, which actually helps feed into many studies. So we can keep that going, and having people sitting at the table and hiring from the community. We've been totally engaged with the community, so it perpetuates not only what we want to do, but sometimes the community comes up with studies or questions that they want to have answered that we have to do anyhow, even though we want to pull back to the cancer side, but we must really serve the community because that's what we're there for. And I think that's going to end our session because I see the hook coming out. Thank you very much.